Welcome to the deep dive. Today, we're tackling a really significant area, endocrine medications.
Yeah, it's a big one.
Think of this as your streamlined guide. We want to help you understand how these really powerful drugs work in the body.
Exactly. We've basically pulled the essential information from a comprehensive chapter, specifically the one on endocrine meds from the Saunders Comprehensive Review for the NCLEX-PN Examination, 7th edition.
Right, giving you the need-to-know stuff for this, crucial area of pharmacology.
Our goal is pretty straightforward. Give you a clear grasp of the key concepts. Doesn't matter if you're new to this or just need a solid review.
We'll be covering, well, quite a bit. Everything from the pituitary gland hormones all the way through to the various treatments for diabetes mellitus.
It's a practical approach based on that nursing review chapter, so we'll get into the real-world implications.
We're going to untack pituitary medications, antidiuretic hormones, thyroid and antithyroid agents. What else?
Parathyroid medications, corticosteroids, both mineralocorticoids and glucocorticoids, androgens, estrogens, progestins.
Fertility medications too, and of course all those diabetes drugs. It's quite the landscape.
It is, but we'll hit the critical points you really need.
And to get us thinking clinically right off the bat.
Let's use a scenario. Okay, imagine this. You have a patient with diabetes who takes metformin every day. They're scheduled for a CT scan that uses iodine contrast.
Okay.
What should the nurse prioritize? What's the most important first step?
Good question. Keep that in mind, folks. As we go through our deep dive, we'll definitely circle back to the answer at the end.
All right.
Okay, let's dive in, starting with the pituitary gland. This tiny gland at the base of the brain, it has a huge job, doesn't it? Controlling so many other glands.
Absolutely. It's got two main parts, the anterior and the posterior pituitary, and they each do different things.
So the anterior pituitary, what's its role?
Think of the anterior pituitary as like the hormone production powerhouse. It makes and releases several really vital hormones. Well, there's growth hormone, GH, pretty self-explanatory, key for growth. Then thyroid-stimulating hormone, TSH, tells the thyroid what to do. Adrenocorticotropic hormone, ACTH, stimulates the adrenal glands.
Okay.
Also prolactin for milk production, melanocyte-stimulating hormone, MSH for skin pigment, and then the gonadotropins FSH and LH, which are crucial for reproduction.
Wow, quite a list. And the posterior pituitary makes different hormones.
Well, actually, it's a slight correction there. The posterior pituitary doesn't produce its own hormones. It stores and releases two important ones that are actually made in the hypothalamus.
Okay, which ones?
Antidiuretic hormone, ADH, also called vasopressin, that helps with fluid balance.
Yeah.
And oxytocin, involved in things like bonding and uterine contractions.
Got it. So let's focus on those growth hormone medications first. You mentioned GH deficiency.
Right. Medications like somatropin, norditropin, macrosermin, they're used when the body just isn't making enough GH. Could be in kids or adults.
So if you have a patient on GH therapy, what are the important things, the nursing considerations?
Monitoring is huge. For a child, you absolutely have to track their growth regularly. Use those standard growth charts to see if the medication's working.
Makes sense.
And annual bone age checks can tell you a lot about their growth progression. Plus, you need to keep an eye on vital signs, blood glucose levels. GH can mess with glucose metabolism,
Right.
Also, liver function tests like AST and ALT, and thyroid function tests too, because things can interact.
And what about patient and family education? What do they need to know?
Oh, that's critical. They need to be able to spot the signs of hyperglycemia, high blood sugar. They also need the rundown on potential side effects and why those regular follow-up blood tests are just non-negotiable.
Okay.
It's also worth mentioning there are drugs that block growth hormone effects, growth hormone receptor antagonists. Things like lanreotide, octreotide acetate, pegvisomant. They're used when there's too much GH.
Interesting. Okay, let's move on to antidiuretic hormones. ADH, vasopressin. You mentioned desmopressin, acetate, and vasopressin. What's their main job?
Their primary function is to make the kidneys reabsorb more water, basically telling the body, hold on to water, which means you produce less urine. It's all about maintaining fluid balance.
So when would you typically see these prescribed?
The main use is for diabetes insipidus. Now remember, this is not the same as diabetes mellitus, the blood sugar one.
Right, different condition.
Yeah, diabetes insipidus is about trouble regulating fluids, causes intense thirst, lots of dilute urine. Desmopressin is really common for managing that.
And vasopressin.
Vasopressin can be used for diabetes insipidus, but it has another really important role. It's often used in septic shock to help raise blood pressure because it constricts blood vessels.
Gotcha. What about side effects with these ADH meds? What should we watch for?
Common things might be skin flushing, headache, nausea, maybe some abdominal cramps. The big one to worry about, though, is water intoxication.
Water intoxication.
Yeah, if the body holds on to too much water, that can even lead to hypertension, high blood pressure. And if it's given nasally, like desmopressin sometimes is, nasal congestion can happen.
So, key nursing interventions.
You've got to be meticulous about monitoring intake and output. Track daily weight. Check electrolytes, urine-specific gravity that tells you how concentrated the urine is. Monitor blood pressure.
And be alert for
Signs of water intoxication. Things like confusion, headache, nausea. Patient education is vital here, too, to teach them to report those signs, or any persistent headache or shortness of breath.
Okay. Next up, thyroid hormones. These are all about metabolism, right? How our body uses energy.
Precisely. Thyroid hormones set the pace for our body's cells. They influence heat production, oxygen consumption, all that. The main replacement meds are levothyroxine sodium, liothyronine sodium, Liotrix, and thyroid desiccated, basically synthetic or natural thyroid hormones.
And the main reason for using them is when the thyroid's underactive, hypothyroidism.
Exactly. Used to replace what's missing in hypothyroidism. Also used in really severe cases like myxedema coma, which is a medical emergency.
Are there important drug interactions we need to know about?
Oh, definitely. Thyroid hormones can boost the effect of blood thinners, like warfarin, and also some stimulants and antidepressants.
Okay.
But they can decrease the effectiveness of insulin, oral diabetes meds, and digoxin, a heart drug. And some other meds, like phenytoin and carbamazepine, can actually reduce how well thyroid hormones work.
The timing of taking thyroid meds seems important too. I've heard that.
It really is. For best absorption, you need to separate thyroid hormone doses by at least 4 hours from things like multivitamins, certain antacids, the ones with aluminum, or magnesium hydroxide.
Like Tums or Mylanta.
Some of those, yeah. Also, simethicone for gas, calcium carbonate, bile acid sequestrants for cholesterol, iron supplements, and sucralfate for ulcers. They all interfere with absorption.
Wow. Okay, so what about side effects from thyroid hormones?
Can include things like nausea, maybe decreased appetite, cramps, diarrhea, weight loss. Because they rev up metabolism, you might see nervousness, tremors, trouble sleeping, sweating, feeling hot.
Makes sense.
And cardiovascular effects, too fast heart rate, tachycardia, irregular rhythms, dysrhythmias, palpitations, chest pain, high blood pressure. Headaches are possible too. If the dose is too high, you basically get symptoms of hyperthyroidism, an overactive thyroid. That's toxicity.
So for nurses caring for these patients, what are the key takeaways?
First, get a really good medication history. All drugs, supplements, everything. Monitor vitals and weight regularly. And track your thyroid hormone levels, T3, T4, TSH.
And patient teaching.
Super important. Teach them. Take it same time every day, usually morning, empty stomach. How to check their pulse. Which foods or meds might interfere. Be aware of side effects. And crucially, do not stop taking it abruptly. Got to stress that.
Right. Okay, let's flip the coin and talk antithyroid medications. For when the thyroid is overactive, hyperthyroidism.
Exactly. Meds like methimazole, propylthiouracil, often called PTU, and potassium iodide strong iodine solution, used for hyperthyroidism or Graves' disease, which is a common cause.
What kind of side effects might pop up with these?
Can see nausea, vomiting, diarrhea, drowsiness, headache, fever. Sometimes hypersensitivity reactions like a rash. A really serious one, though rare, is a granulocytosis.
A granulocytosis? What's that?
It's a sharp drop in white blood cells, specifically neutrophils. Makes patients very vulnerable to infection. Other possibilities are hair loss, skin pigmentation changes, and if the dose is too high, it can swing the other way and cause hypothyroidism.
You mentioned strong iodine solution, Lugol's solution. Any special concerns there?
Yes, something called iodism. Symptoms can include vomiting, belly pain, a metallic taste, rash, sore gums, or salivary glands. Because of this, it's usually used short-term, maybe for a couple of weeks, often before thyroid surgery for hyperthyroidism.
So important nursing actions for patients on antithyroids.
Monitor vitals, thyroid levels, T3, T4, TSH, and weight. Educate them to take it with meals if it upsets their stomach. Teach pulse monitoring again. Make sure they know the side effects and when to call their provider.
And recognize signs of
hypothyroidism if the dose is too high. Stress medication compliance, stopping suddenly, can trigger a thyroid storm, which is life-threatening.
thyroid storm. What does that look like?
High fever, flushed skin, confusion, really fast heart rate, irregular rhythms, even heart failure. They need to know those signs.
Got it. Okay, parathyroid medications. This is all about calcium regulation, isn't it?
Precisely. Parathyroid hormone, PTH controls blood calcium. Low calcium triggers PTH release. Hyperparathyroidism means too much PTH, high calcium, and potentially calcium leaching from bones. Meds are used to lower calcium.
And the opposite, hypoparathyroidism.
Not enough PTH leads to low calcium, which can make nerves and muscles overly excitable. Treatment there is usually calcium and vitamin D.
Any significant drug interactions involving calcium or these meds?
Yeah, calcium supplements can increase the risk of digoxin toxicity, and they can reduce the absorption of tetracycline antibiotics.
Okay. Essential nursing interventions for parathyroid issues.
Monitor electrolytes, especially calcium. Be vigilant for signs of both low calcium, hypocalcemia, and high calcium, hypercalcemia. Watch for tetany muscle spasms with low calcium and kidney stones with high calcium.
That's a lot to monitor.
It is. Patient education is huge. Teach the signs of high and low calcium. Tell them to check OTC med labels for hidden calcium. Stress adequate vitamin D intake. It helps absorb calcium.
And specific medication instructions.
Depends on the drug. For bisphosphonates like alendronate, take it right, empty stomach, full glass of water, 30 minutes before food. Stay upright for 30 minutes. For calcitonin nasal spray, alternate nostrils.
Any dietary advice?
If they're on meds to lower calcium, advise limiting high calcium foods, leafy greens, dairy, shellfish, soy. Separate calcium supplements from other meds by at least an hour, and boost fluids and fiber to prevent constipation from the calcium.
There seem to be a lot of meds in this category.
There are various calcium forms, vitamin D types, bisphosphonates like alendronate, abandronate, zoledronic acid, calcitonin, and others like cynic acid that directly target PTH.
Okay, let's shift to corticosteroids. Two types, mineralocorticoids and glucocorticoids. Start with mineralocorticoids. Fludrocortisone is the main one.
Correct. Fludrocortisone acetate. Mineralocorticoids primarily act on the kidneys. They make the body reabsorb sodium and chloride and excrete potassium and hydrogen. It's all about fluid and electrolyte balance.
And its main use?
Primarily for adrenocortical insufficiency Addison's disease, where the adrenal glands don't make enough of their own steroids, including mineralocorticoids.
Potential side effects, given the effect on sodium and potassium.
Exactly. You can see sodium and water retention, which leads to low potassium, hypokalemia. This can cause high blood pressure, swelling, edema, weight gain.
Anything else?
Oh, yeah. Negative nitrogen balance, osteoporosis, muscle weakness, slow wound healing, high blood sugar, more risk of infection, cataracts, hirsutism, extra hair growth, acne, fragile skin, bruising, slow growth in kids.
Wow.
And GI irritation, peptic ulcers, pancreatitis, seizures, even psychosis, and adrenal insufficiency if stopped abruptly after long use.
That's a hefty list. Okay, now glucocorticoids. This is the bigger group, right? Prednisone, dexamethasone.
Yes. Glucocorticoids have really broad effects. Potent anti-inflammatories. They affect metabolism of carbs, proteins, fats, involved in the stress response. They also suppress the immune system.
Lots of familiar names here. Betamethasone, cortisone, hydrocortisone.
Methylprednisolone, prednisone, triamcinolone, widely used.
Given these wide effects, any contraindications or major cautions?
Generally avoided if someone's hypersensitive, has psychosis, or active systemic fungal infections. Used very cautiously in diabetes because they hike up blood sugar, and extreme caution with any infection because they can mask the symptoms.
What about interactions with other drugs?
Several important ones. They increase the risk of GI bleeds with aspirin and NSAIDs. Taking them with potassium-wasting diuretics worsens potassium loss. Dexamethasone can make oral anticoagulants and diabetes meds less effective. And drugs like barbiturates, phenytoin, rifampin can reduce prednisone's effect.
Okay. Moving on to androgens. Male sex hormones, primarily.
Yes. Things like methyltestosterone, various testosterone preparations. They handle the development and maintenance of male characteristics.
Important interactions or contraindications?
They can increase bleeding risk with oral anticoagulants. They can lower blood glucose, so diabetic patients might need insulin adjustments. Best to avoid other liver-toxic meds concurrently, and generally avoided in men with prostate or breast cancer, as they might stimulate tumor growth.
Side effects of androgen therapy?
In women, you can see masculinizing effects. In men, priapism, that's the prolonged painful erection, baldness, low libido, gynecomastia, breast enlargement, prostate enlargement, also edema, weight gain, and potential liver damage.
Liver damage signs?
Upper right quadrant pain, feeling unwell, fever, jaundice, yellow skies, itching.
Nursing considerations for androgens?
Monitor weight, blood pressure, liver function tests. Assess for those secondary sexual characteristic changes. Advise taking oral forms with food. Tell patients to report priapism or fluid retention immediately. Women need reliable non-hormonal contraception. Also monitor women for menstrual changes or decreased breast size.
Okay, let's tackle estrogens and progestins.
Hmm.
Female hormones, often used together.
That's right. Estrogens like estradiol, conjugated estrogens, used for hormone replacement therapy, contraception. Progestins like levonorgestrel, medroxyprogesterone, often combined with estrogens for birth control.
How do progestins work in birth control?
They mainly stop ovulation and thicken cervical mucus, making it hard for sperm. Progestin-only pills are generally a bit less effective than combination pills.
How are the combination pills usually taken?
Typically 21 days of active hormones, then 7 days off for placebo pills. That's when withdrawal bleeding, like a period, usually happens. Then start the next batch.
Any major contraindications or cautions for hormonal contraceptives?
Definitely. Usually not for women with high blood pressure, history of blood clots, stroke, coronary artery disease, certain estrogen-dependent cancers, or during pregnancy. Smoking, obesity, hypertension increase risks. Caution with liver disease, too.
And interaction.
Can interfere with bromocriptine and anticoagulants. Can increase toxicity of tricyclic antidepressants. May alter blood glucose. Diabetics need careful monitoring. And importantly, some antibiotics can make oral contraceptives less effective.
Common side effects.
Breakthrough bleeding between periods, maybe more cervical mucus, breast tenderness, sometimes hypertension, nausea, vomiting.
Key nursing education points for users.
Monitor vitals, weight, teach correct administration for their specific type. Advise backup contraception, like condoms, when starting or if taking certain antibiotics. Diabetics need vigilant glucose monitoring. Instruct on reporting signs of blood clots, leg pain, swelling, chest pain, shortness of breath. Report unexpected vaginal bleeding or suspected pregnancy. Encourage monthly breast self-exams, annual physicals.
Wow.
Explain patch application where weekly change, rotation, what if it falls off. Same for vaginal rings, insertion, removal, disposal. Mention long-acting options like implants, injections. And if stopping to get pregnant, advise using another method for a couple of months first.
Right. Quick touch on fertility medications. What's their main goal?
Drugs like clomiphene, folotropins, HCG, they stimulate follicle development and ovulation in women whose ovaries still function. HCG often helps maintain the follicle after ovulation.
When shouldn't they be used?
Generally not with primary ovarian failure, untreated thyroid or adrenal issues, ovarian cysts, pregnancy, or unexplained uterine bleeding.
Nursing considerations for fertility treatments.
Emotional support is huge. Infertility is stressful. Help with treatment schedules, timing intercourse. Inform about the increased risk of multiple births. Crucially, educate on signs of ovarian hyperstimulation syndrome, OHS, and when to report it. Regular follow-up is essential.
Okay, deep breath. Now, medications for diabetes, mellitus, insulin, and all the others. Let's start with the basics. How do they manage blood sugar?
Insulin, whether injected or pumped, basically unlocks the cells so glucose can get in for energy. It also tells the liver to store glucose as glycogen. Both actions lower blood glucose.
And the non-insulin meds.
They work in all sorts of ways.
Yeah.
Some boost insulin production, some make cells more sensitive to insulin, some reduce glucose output from the liver, some slow sugar absorption from the gut, some enhance natural incretin hormones, some make the kidneys excrete more glucose. Lots of mechanisms.
Any general contraindications or big concerns?
Well, insulin allergy, obviously.
Yeah.
Most oral meds, except SGLT2 inhibitors, don't work for type 1 diabetes. They need insulin. Beta blockers can hide hypoglycemia symptoms, which is risky.
Drug interactions.
Some drugs increase hypoglycemia, risk certain anticoagulants, antibiotics, aspirin. Others can raise blood sugar, corticosteroids, sympathomimetics, some diuretics. And sulfonylureas plus alcohol can cause a nasty disulfiram-like reaction.
There are so many classes of non-insulin meds. Can you give us the quick rundown, like metformin?
Metformin is a big one. Reduces liver glucose production, increases insulin sensitivity. Then sulfonylureas, glipizide, glyburide, they stimulate the pancreas to release more insulin.
Liglitinase?
It's like repaglinide. Also stimulate insulin release, but shorter acting, taken with meals. Thiazolidinediones, TZDs like pioglitazone, improve insulin sensitivity, reduce liver glucose output.
Keep going.
Alpha-glucosidase inhibitors, acarbose slow carb absorption in the gut. DBP4 inhibitors, sitagliptin-enhanced incretins, boosting insulin and lowering glucagon.
SGLT2 inhibitors.
Like canagliflozin, make kidneys pee out more glucose. Lowers blood sugar, can help with weight loss. Then there's bromocriptine, a dopamine agonist, less clear mechanisms.
And the injectables, besides insulin?
Incretin mimetics, or GLP-1 receptor agonists, exenatide, liraglutide, slow digestion, boost insulin, reduce glucagon, curb appetite, and amylin emetics, pramlintide, also slows digestion, suppresses glucagon used with insulin.
So key teaching points for patients on these non-insulin meds.
Monitor blood glucose and A1C. Understand their specific drugs action, side effects, especially hypo, importance of diet, exercise, how to check sugar, recognize and treat lows. Wear a medical alert ID.
Anything specific for metformin?
Monitor kidney function, risk of lactic acidosis. Needs to be held before after IV contrast studies. That's the link back to our scenario.
Ah, right.
Sulfonylurea is caution with kidney liver problems. Avoid alcohol. Meglitinides and alpha-glucosidase inhibitors take with the first bite of the meal.
Okay, now let's really focus on insulin itself. We know it gets glucose into cells, used for type 1 and often type 2, right?
Correct. Essential for type 1, very common in type 2 when other agents aren't enough.
And the different types, rapid, short, intermediate, long-acting. Can you summarize the timing, onset, peak, duration?
Sure. Rapid-acting Lispro, Aspart, Glulazine starts in like 10-30 minutes. Peaks 0.5 to 2.5 Atchers, lasts 3 to 6 Atchers.
Yeah.
Short-acting, regular, starts 30-60 minutes, peaks 1 to 5 Atchers, lasts 6-10 Atchers.
Intermediate.
NPH starts 1-2 Agers, peaks 6-14 Agers, lasts 16-24 Agers. Long-acting, Glargine, Detamir, starts around 1 year, minimal peak, lasts 18-24 plus Agers. And then you have premixed combos.
Storage and administration seem really specific. Key points.
Store properly, avoid heat, cold, freezing, direct sun. Unopened vials, refrigerated. Open vials usually good at room temp for a month, but check specifics.
Injection sites.
Abdomen, fastest absorption, back of arms, thighs, hips. Rotate sites within an area. Don't use the exact same spot for 2-3 weeks. Avoid scar tissue. Heat, massage, exercise nearby can speed absorption risk of hypo.
Drawing up insulin.
Attach syringe unit to insulin concentration, usually U100. U500 needs a special syringe. MPH is cloudy, gently roll or invert to mix, don't shake. Clear insulins don't need mixing.
Mixing insulins.
Drop clear, short rapid before cloudy MPH. Give mixed dose within 5-15 months. Don't mix long-acting Glargine or Detamir with anything.
Injection technique.
Aspiration usually not needed for self-injection. Angle is 45-90 degrees, depending on fat layer. Only rapid short-acting can go IV.
And patient education for insulin is critical.
Yeah, absolutely. Injection technique, site rotation storage, recognizing and treating hyperglycemia, meal planning, exercise, sick day rules. Insulin needs often increase when thick. Compliance, wearing ID. It's a lot.
You mentioned the other injectables, GLP-1 agonists and pramlintide. How are they given?
GLP-1s are usually pre-filled pens, refrigerated injected sub-Q, thigh, abdomen, arm, usually before meals, some daily or weekly. Give other oral meds 1 hour before. Pramlintide also sub-Q before meals with insulin. Refrigerate unopened, opened okay at room temp up to 28 days. Give other oral meds 1 hour before or 2 hours after pramlintide due to slowed stomach emptying.
Okay, one last one. Glucagon. What is it? When is it used?
Glucagon is a hormone, the opposite of insulin. It tells the liver to release stored glucose, raising blood sugar. Available as injection, sub-Q, IM, IV. Used for severe hypoglycemia when the person can't take sugar, orally unconscious or semi-conscious. Works in 5-20 minutes. Family caregivers need training on how to use it.
Wow. Okay, that was an incredibly detailed journey through endocrine medications. We really covered the gamut from the Saunders chapter. Now, let's revisit that critical thinking scenario. Patient on metformin, scheduled for CT with iodine contrast. Priority nursing action.
Right. The absolute priority is for the nurse to notify the RN and the primary healthcare provider immediately about the metformin use. As we touched on, metformin needs to be held, usually 1 to 2 days before and for 48 hours after IV iodine contrast.
Why again?
Because of the risk of contrast-induced nephropathy kidney damage, which can then lead to lactic acidosis if metformin built up. It's a serious potential complication. The provider gives the specific start-to-start orders.
Perfect. So to wrap up, we've navigated the complex world of endocrine meds, hitting mechanisms, uses, side effects, interactions, and those all important nursing considerations and patient teaching points, all drawing from that comprehensive Saunders review chapter.
Definitely. For further thought, maybe consider how interconnected the endocrine system is. A disruption in one hormone can really cause ripples, and think about how these meds try to restore balance and the challenges in fine-tuning that.
Good point. And maybe think about the research pipeline, what new treatments are coming.
Yeah. And here's a final thought to chew on. With our understanding growing, how might endocrine medication therapy become even more personalized in the future? Moving beyond just drug classes to really tailor treatment to the individual's specific hormonal profile or genetic makeup.
Interesting direction. Well, thank you for joining us on this very thorough deep dive into endocrine medications.
Thank you. And just to confirm for everyone listening, we have now comprehensively covered the key content regarding endocrine medications as detailed in the relevant chapter of Saunders Comprehensive Review for the NCLEX-PN Examination, 7th edition. We've hit the nursing concepts, assessments, procedures, safety priorities, and integrated review questions throughout our discussion, defining terms as we went.